now we have to make the decision. Do I send her home and tell her, well, this is probably just the stress you're in, and maybe you have a little bit overweight, that puts some pressure on your back, and this may cause some problems in your vertebral column, and the pain may come from there. And we may even give her a diclofenac or something, or paracetamol. Or are we cautious and we send this patient to the cardiologist? Or we do an exercise electrocardiogram? What do we do? If we, oops, I missed one. Let's send her to the exercise electrocardiogram. Either we do it, in Germany we do it, in Austria it's not done by GPs. It's different from country to country. So, but anyhow, if you send this patient to a cardiologist, what will he do? The cardiologist will all do exercise electrocardiogram. He won't even think of it. So the decision in which direction this patient goes lies with you as a GP. And now what happens with the exercise electrocardiogram? The sensitivity of the exercise electrocardiogram is about 60%, the specificity is about 90%, and we can do our 2x2 table again. And what do we come up with? If she has a positive result of the electrocardiogram, that means that her positive predictive value will go up to 58%. But still, I mean, that's a little over half. That's a little bit like rolling dice still. You know, it's about half the chance you got it and half the chance you don't have it. If it's negative, we can be pretty sure the patient doesn't have anything. But if it's positive, it's still uncertain. What will the cardiologist do? With a positive predictive value of almost 60%, this patient will go to coronary angiography. Of course it will. And that's the picture we have from the studies of coronary angiography, that about 60%, between 50 and 60% turn out to be positive, that actually coronary heart disease is discovered, and about 40 to 50% are made with no result, and the patient will be sent home anyway. So is it a risky examination, coronary angiography? Well, the frequency is not very high of complications. It's about 0.8%. But still, it's a risk, and any invasive examination that uses contrast, that includes the risk of bleeding, of myocardial infarction, coronary spasm, arrhythmias, allergic reactions, acute renal failures due to contrast. I mean, that's a risk, right? That's posing a threat to patient safety. And the decision whether this risk is taken is with us. It's not the cardiologist, because the cardiologist won't even decide. If we send the patient to the cardiologist, that's the decision that decides in which direction things are going. So we don't amputate the wrong leg in primary care, but we make some very, very principal decisions that decide where the patient goes. And that's what patient safety in primary care is about, at least in the diagnostic part. That's a lot of pressure on us, isn't it? We got about 6 to 10 minutes to take a history, to do the physical examination, to explain to the patient the options there are. We have to come within these 6 to 10 minutes to a decision. Watch and wait, further diagnostics at the surgery, or do we refer the patient to the cardiologist? And after 6 minutes, this patient walks out of our door, and we may not see him again, because will go to the cardiologist, and he will go straight to the coronary angiography. He will go straight to the hospital. He will get a stenting because of his 52% stenosis that's discovered. And then he will take anticoagulation for a year. Is that good for the patient? Maybe not. Maybe it is. The evidence for interventional cardiology is not really very promising, as you all know. Now, and we do this not only once a day, we do it in an average of 40 times per day. And that makes up the 30-some million diagnostic decisions that are taken in primary care. And of course, there are a lot of these decisions where it doesn't matter. I mean, you know, we have a lot of patients, and they just come because they have a cold or flu, and our decision doesn't really matter. There is a saying in German, I don't know whether it's in English, you use it too, the flu takes 7 days with cure and 1 week without, right? So it doesn't really matter, but there are some decisions and that have very wide consequences for the patient, and these need to be taken in our everyday routine with a lot of time pressure. So that's a good thing to say to the patients and to save some time. Possible solutions: clinical decision support, maybe one. That we do use decision support, decision aids that can be computerized or it can be on paper. It's now probably more on computers. But I think the most important thing would be to have more time for these patients and have less patients to deal with. We did a study in Salzburg on a computerized decision aid for preoperative diagnostics. We all know that preoperative diagnostics, a lot of unnecessary examinations are done. And we took a look at 1,300 consecutive patients in a Salzburg hospital that came for elective surgery. And these are the percentages of the patients that received these exams, in spite of the fact that from the anesthesiology guideline, they wouldn't need that. So that's between 20% for the electrocardiogram and more than 80% for coagulation tests. And then we developed a tool together with IT specialists in Salzburg to give the GP a short computer program where, you know, when a patient comes for preoperative diagnostics, they have to fill out a form. Now, this form is imported directly or done directly in the computer, and then the computer checks the guideline which exams should be taken and tells the GP, okay, with this patient I need a complete blood count and an ECG, but nothing else. Or I need only the history and the physical examination, which is the case in more than 60% of elective surgery. Now, this is the result of guideline adherence. We did a study. The left column is before, so the average of the exams that were taken before, and the guideline adherence was only 40%, and it rose up to more than 80% with this decision tool, and it was even a little bit better in the guideline adherence in the GP surgeries than in the hospital when the preoperative diagnostic was done in the hospital. So this is a very good instrument to improve diagnostic procedure. And I think for many diseases and complaints or symptoms the patient comes with, we can develop these decision aids to improve our diagnostics. That I'm afraid we tend to overestimate our own knowledge and our gut feeling. Well, I know what this patient has, and this can be very erroneous. Okay, next subject, drug therapy and patient safety. Drug therapy, it's very similar. We have to make many, many, many decisions. We have to make them quickly. And we have patients that take not only one medication, but we have in primary care the problem of polymorbidity, of adherence, of transferability. Is our study results transferable to my patient, and of polypharmacy, and especially transferability of studies in polypharmacy, because most studies on the effects of medication in chronic care are done with selective patients that only have the disease that you want to treat, but this is not the typical patient we find in our office. So it's very difficult to make a decision and what medication should I give to the patients, and usually he comes out of the hospital and he gets everything and some additional medication that's unnecessary too. But again, it's the same thing as with diagnostics. Patient harm can be caused by omitting drugs, by not giving drugs. But patient harm can also be done by prescribing drugs. We took a look at diabetes. We did a randomized controlled trial in Salzburg on disease management, on the implementation of disease management in diabetes, and these are the baseline data, and there are about between 35% and 40% of these type 2 diabetics that don't have metformin. Okay, maybe not everybody needs it, but even if we take the patients out of this cohort that have an HbA1c above 7.5, which is more than the recommended threshold, and they don't have contraindications against metformin, there are still 25% of these patients that don't have metformin, and they should have it. Most of them should have it. And there are probably a few that tried it and they couldn't take it because they had side effects, but not 25%. So what's with the rest, with the 15 to 20% of the patients who don't get this drug that's actually the only one that has been shown to be effective in long-term prevention of diabetes complications? Well, we don't know. I'm actually doing a little research right now with medical students, and we ask patients and GPs about the reasons why they deviate from guidelines. And we're looking forward to the results of that study because I think that's very interesting. It's not only the metformin, it's in this cohort, the same cohort, there are about 20% of the patients that don't have any anti-diabetic medication. There are almost 60% of these patients don't have a statin, and there are 20% that have hypertension but don't have antihypertensive treatment. So it's manifold. The problem that guideline adherent therapy is not given. And doctors seem to be pretty resistant to medical education. This is a study from the UK, and they checked guideline adherent care for blood pressure, and then they administered an intensive continuous medical education unit to these GPs, and after 3 months, They looked again, I think it was between 3 and 6 months, and of course it increased a little bit, but still it's only 50%, which is a pretty sad result.